pediatric grand round. Today's the last grand rounds of this academic year. We'll take a break over the summer and resume on September 2nd. So today's speaker is Dr. Laura Blaisdell, who many of you know, but what you may not know is that while at Carleton College, where Frisbees rule, she was a member of the women's ultimate team, so quite an accomplishment. She then went on to get an MPH and MD at the University of Minnesota. She did a residency training at Maine Medical Center. She has been practicing general pediatrics as well as being involved in clinical research. She's been active in the Maine AAP and led the effort to tighten Maine's immunization laws. Today, she'll give us an update on Maine's vaccine law. So thank you and welcome, Laura.
Thank you so much, Carol. I really appreciate being here. I'm speaking to you from and so that is why my Zoom background is a little more campy. So I'm going to go ahead and share my screen and start here. So today we are going to talk about Maine's new vaccine law and what pediatricians need to know. If you would like to text your attendance to this number 43976, you can get your CME credit that way. In terms of conflict of interest, I have no financial conflicts of interest to disclose. I do want to disclose that I'm a founding member of Maine Families for Vaccines, and I was the co-chair of the No on One referendum committee. I'm a board member of Science and Families Engaging for Communities Action Fund, which is a national action fund like Maine Families for Vaccines. And I'm the vice president of the Maine AAP, but I do not and have not received any compensation for those activities. So today we're going to talk about what brought us to requiring a new law in Maine. We're going to talk a little bit about what levers there are to increase community immunity, understand Maine's new vaccine law and its implications, learn what vaccines are covered or not covered by the law, discuss a concept of proof of immunity, discuss medical exemptions and what constitutes a medical exemption from the ACIP perspective, talk about catch-up immunizations, and then a little Q&A. I will be monitoring the Q&A box, so if you have questions, please feel free to put them in there. As everybody knows, I'm a big interactive person on the chat box on Zoom. So when we think about vaccine exemptions in Maine, Maine was one of 18 states that were allowing exemptions based on religious, medical, and philosophical beliefs. The kindergarten non-medical opt-out rate was climbing from 2014 to 2019, as you can see in the right graphic from Portland Press Herald, and medical exemptions went up 0.3% during that same period of time. Maine's opt-out rates was 3 times the national average rate of kindergarten opt-outs, which was 1.8 in 2017 and 18. So before the law, a shocking 48% of kindergartens had a vaccine rate that was below the community immunity thresholds for the diseases that we require immunization for school entry. So not surprisingly then, in 2018 alone, we saw various outbreaks. We had pertussis in multiple schools and daycare centers. Maine had the highest national rate of pertussis in 2018 and 19. There was chickenpox outbreaks at multiple schools. We did have that mumps outbreak among college students at Southern Maine, Bates, and Bowdoin. And other than one reported case in 2013, no Maine mumps outbreaks occurred since 2007. And then we had that singular case of measles in 2017, which was our first case since 1997. And luckily there was no transmission from that single case. So I think at now, having gone through a pandemic, most of us understand the function of community immunity. Community immunity is what protects us from transmission when vaccination alone does not. It's a factor of transmissibility, and the severity affects that threshold or the minimum percentage of immune individuals that a community needs to prevent an outbreak. So R naught, which we've all heard about now, 2 represents how many people people in an unprotected population, one infected person could pass the disease to. So you can see here, measles has an R naught of 12 to 18, which means that you need higher herd immunity thresholds. And you can see, flu has that R naught between 1.5 and 1.8, so that the herd immunity threshold is much lower. As we watch the changing variants in COVID, this basic reproduction number is what we're looking at. So it's looking like the original COVID wild type virus had a lower R naught than we're seeing with Delta, which is why we're talking about our vaccination rates and the percentages that we need to get to achieve community immunity. So there are many different levers that we try to pull when we are trying to increase community immunity. I think many of us in public health know that for basic education, we've been trying to do basic education about vaccines. We try to increase the access by increasing coverage or increasing points of care, by paying for vaccines as we do in Maine. You can change some ways at point of care of making vaccinations more easy to access by reminding and recalling busy families, by tracking and incentivizing immunizations, and by having immunization standing orders so that physicians aren't necessarily being needed to do a order for each immunization. And I also want to commend Maine Medical Center's BBCH inpatient unit for making that point of care another point of care for children to receive their standard immunizations. When those things don't work, we start to look at more coercive measures at a larger, either at a system level or a public health level. You can certainly do a penalty. So in Europe, there were a couple of countries that were doing a $3,000 penalty if you were not vaccinated against measles when they were having outbreaks. You can do a mandate. A mandate is like we're seeing in our schools, like as a condition of attending public school or private school, you need to be vaccinated. And you can also make vaccinations compulsory, which would be just making them essential and a criminal a criminal outcome if you were not vaccinated. And of course, there's outbreak management, which is what we try not to do in terms of improving community immunity. So vaccine laws that we have on the records have varying degrees of effect, significant effects and exemption rates. Excuse me, I'm having a screen space issue. I'm just going to take a moment and make more room for me. Significant effect in exemption rates that were found in policies that required a health department approval for non-medical exemptions, having a physician sign an exemption application, or having criminal or civil punishments for non-compliance. Some laws actually can increase vaccine exemptions. Having a common form for exemptions makes it, hypothetically easier for people to exempt, and then of course allowing philosophical exemptions increases vaccine exemptions. And we know from this study from Bradford and Mandich that exemption law effectiveness does lower the incidence of infectious vaccine preventable diseases. So as we know, Maine joined joined West Virginia, Mississippi, and California in 2019 in removing philosophical and religious belief exemptions. Shortly after, New York joined after their measles outbreak, and Connecticut just joined this group in just this past year. New Jersey has tried and is going to be trying again soon. There was a little bit of a discussion about whether or not one should a state should adjust remove personal beliefs, which Vermont tried in 2016, but then they saw their religious rates increase by the number of philosophical exemptions in the previous year, which has led a cautionary tale to states who have gone forward in the future in removing religious and physical personal belief exemptions. So Maine passed the law in 2019, and then I want to thank so many of us because we had a little bump in the road per the referendum that we were able to defeat. And I want to thank each and every person who led their support. It was really an essential aspect of advocacy to have such robust and almost complete support from the medical community. But now we have a medical exemption only for as a condition of public school entry, private school entry, daycare, starting in September of this year, September 1st, 2021. So let's talk a little bit about that and get into the details of Maine's vaccine law. So it previously allowed religious or philosophical exemptions for elementary and secondary schools, private and public, post-secondary schools and colleges, nursery schools or childcares, and healthcare facilities. The new law removes that exemption verbiage from regulation, and the DOE and DHHS have been instructed to remove any immunization exemptions based on religious or philosophical beliefs from their rules. There is also a grandfathering opt-out rule that requires the DOE to adopt rules that have students who have an IEP on September 1st of 2021 who have elected philosophical or religious exemptions to continue to attend school under existing exemptions as long as a medical professional provides a statement of counseling of the risks and benefit associated with the choice to immunize. I think it's important to note here that there is nothing medically fragile about students who have IEPs. This is a policy decision in terms of how the legislation was created and the hopes to not trigger FAAP, free access to public education, and IDEA laws for students with IEPs. So this is a little bit of a carve out that doesn't have a medical, but more of a legislative and political ramification potentially. So our law in Maine is actually a revisionary law. So it is not a piece of legislation in and of itself, but in the sense that it was written in its entirety. It actually is a law that talks about we're just removing the verbiage of religious and philosophical belief exemptions from multiple set of regulations. So for those who aren't aware, when a law is made, it's made and passed by the legislature and passed by the governor. And then the governors, the various departments create the regulations or the set of rules that provide the detail to that law and that law's implementation. So this law says wherever there is a regulation that uses religious or philosophical belief exemption in verbiage, we will strike that from those regulations. And as you can see, there are 6 different locations in Maine regulation where those words are used. There are some Office of Child and Family Services rules. There's a joint immunization requirement for schools from the DOE and DHHS or Maine CDC. There's also some post-secondary school immunizations in the Maine CDC, and then healthcare workers. So that is why this law is a little bit more confusing than just for elementary and secondary school students alone. One of the confusing aspects additionally is that the vaccine requirements listed in regulation for each of those various institutions is different depending on that institution. So what vaccines are required for attending school, just private and public school? So we know that for kindergarten, they need 5 DTaps, 4 polios, 2 MMRs, and 1 varicella. And we'll get back to the varicella in a second. For 7th grade, the requirement is 1 Tdap, 1 meninge, and in 12th grade, a 2nd meninge is required if as long as the first dose was given before the 16th birthday. So I want to go back to that varicella. So why is there just one varicella? And I think this is a representation of the time when these regulations were made. So when the original regulations were made, only one varicella was required by ACIP. I think many of us can remember those days, but there were approximately a 25% breakthrough rate with that one varicella. And even though it was a less severe disease, it was still contagious. And so you can see the A is a full-blown varicella outbreak without a vaccine, and B is with the vaccine. But this, even with the vaccine, it was still contagious. So in 2007, the ACIP recommended their 2-dose regimen. But this regulation didn't get updated to reflect that. So at this point, we are moving forward with only needing one varicella, although I think most of us will continue to recommend that children receive 2 doses of varicella. So the ACIP recommendations, you can see that there are vaccines that are recommended by ACIP, but the main school recommendations have a subset of that entire ACIP recommended or CDC or AAP recommended vaccine schedule. So for childcare, looking at a different set of regulations, the childcare required immunizations look somewhat different, look a lot more like the ACIP recommendations. You can see we've added Hib, hepatitis B, Prevnar, and hepatitis A. Rotavirus is on here, but it is not required. So just to remind us that that we still do recommend rotavirus, but it's not required if it for childcare entry. So for post-secondary school, the only requirements are 2 MMRs at the first birthday or 1 TD or 1 Tdap given within the last 10 years. And in order to help put this in sort of a one-stop shop visual spot, Brian, I want to thank Brian Youth and I sat one day in the pediatric clinic and created this vaccine quick sheet to compare what vaccines are required for what institution. And you can find that on maineaap.org. I want to really highlight what vaccines are not included for K-12 schools, both public and private. We don't need hepatitis A, hepatitis B, pneumococcal, HPV, Hib, rotavirus, influenza, or COVID vaccine this year for the K-12 schools. But do want to highlight that these vaccines, hepatitis A, B, pneumococcal, and Hib, are required for childcare entry. One interesting aspect of the regulations from the prior law was a concept of proof of immunity. So many of us know that people could have had chickenpox or had measles, and so we could look for immunity for people who've had the disease. And so those individuals would not require vaccination if they had a demonstrated immunity to that disease from contracting the natural disease. So the regulation does say that the regulation from the prior law, we have not seen the regulation from the current law. We're still waiting for the regulation from the current law, which ends up causing a lot of confusion as we wait for that. But in the prior law, there was a certificate of immunization clause that a physician, nurse, public health official, or school health provider who administered the immunizing agent to the student could certify that the immunizing, I'm going to go back, sorry. So the law, the regulation requires that a physician, nurse, or public health official or school health provider who administered the immunizing agent provide proof of immunization. So the other way to prove immunity is this proof of immunity, which is the laboratory evidence demonstrating immunity from having had the disease or from having been vaccinated. We know that that there is this movement to ask physicians to give one immunization, say 1 MMR, and then look for immunity after that. So I wanted to speak to that for just a minute about why 1 dose isn't enough. So for many For many immunizations, one dose does not generate enough immunity. For some vaccines, primarily inactivated or live vaccines, the first dose doesn't generate the maximum immunity, so a second dose is required. Hib vaccine or MMR vaccine is a good example of that. We know for many of the vaccines that we give that immunity wanes and wears off, so boosters are needed. I think Tdap and DTaP are good examples of that. And although flu and COVID are not required for public school entry at this time, or private school entry either, the new variants require a new vaccine. And so we know that sometimes we need to give additional doses to ensure that immunity continues for the variant of the day. So when a parent comes in and says, can I just have one DTaP, please, and then please check for immunity titers, what do we say? So typically, I recommend that people talk about the proof of immunity really is for proof of natural disease. So if their child actually had the natural disease, you could talk about it, but we don't necessarily do that for vaccinations. And for another reason is just because there are antibodies present doesn't mean a person is immune or will stay immune, right? We're seeing this with our COVID antibodies requests at this point. Additionally, vaccine dosages are based on evidence. And if one shot could be given as a one-time shot and generate adequate immunity, it would have been approved that way. So J&J is a good example of that. And I think it's important for pediatricians and providers to understand that there is a big direct to marketplace lab marketplace, and the National Vaccine Information Center, which is a pro vaccine choice site, does say that private medical laboratories can perform these tests for people who are unable to get the tests from their pediatricians. And just very quickly Google searching, you can see different lab companies that will provide an immunization titer package for less than $200. And that test price includes a doctor's orders. So I think it's really important for us to understand that parents may be going to various labs of varying qualities to get immunization titers. So I'm going to talk now a little bit about medical exemptions. So in the prior law, there was this list that you can see here of what constitutes a medical exemption. Again, the list was not necessarily being updated to reflect ACIP yearly recommendations. And now underneath the new law, the medical exemption can be given if an MD, DO, NP, or PA decide it may be medically inadvisable. So it's left in those larger, broader terms, which is which some enjoy and some are concerned about. So I wanted to spend some time today talking about what are contraindications to various vaccines. So contraindication is a condition that can increase risk for a serious adverse reaction. The majority of medical contraindications to vaccination are temporary, and vaccinations can be given when and administered later when that condition no longer exists. So what are some examples of this? Having severe immunocompromised, being severely immunocompromised, people should not receive live vaccines. Live attenuated viruses, because of a theoretical risk to the fetus, should generally not be given to pregnant women. People who have experienced encephalopathy within 7 days after administration of a previous dose of pertussis that is not explained by any other cause should not receive additional doses of the vaccine that contain pertussis. And then people with SCID or a history of intussusception are both contraindications to rotavirus vaccines, which are live. The next level that the ACIP is precautions. So precautions are conditions that might increase the risk for serious adverse reaction, might cause diagnostic confusion after the giving of the vaccine, or might compromise the ability of the vaccine to produce immunity. A vaccine might be indicated even in the presence of a precaution, if the benefit of vaccination outweighs the risk. So what are some examples of these? Having moderate or severe acute illness with or without fever. Having a severe illness and then receiving a vaccine on top of it could cause diagnostic confusion. I think it's very important to remember that the safety and efficacy of vaccination in mild illnesses has been established. Administering a measles vaccine to a person with passive immunity to measles from a blood transfusion up to 7 months, and sometimes up to a year prior, is an example of precaution that an individual could receive that vaccine if the benefit outweighs the risk. Having recent or upcoming anesthesia, surgery, or hospitalization is not necessarily a contraindication to vaccination, although again, it could, if the reason for any of those experiences might cause diagnostic confusion or might compromise the ability of the vaccine to produce immunity, one might wait. A personal history or family history of seizures is a precaution for MMR, V combined, and that comes from the study that found an increased risk of febrile seizures in children of 12 to 23 months who recently received MMR-V compared with receiving MMR and varicella separately. So another example of a precaution, but MMR-V can be given if the benefit outweighs the risk. So here's a little quiz. Conditions that are incorrectly perceived as a precaution or a contraindication. So let's see how many of us have had or experienced these in our lives. So for all vaccines, having an acute or mild illness with or without fever, being on current antimicrobial therapy is incorrectly perceived as a precaution or a contraindication, as is preterm birth, recent exposure to an infectious disease, receiving alloimmunotherapy, having a history of penicillin allergy, having a history of Guillain-Barré syndrome, and I'll asterisk that by saying unless it was 6 weeks after an influenza vaccine. If if one had 6 weeks after immunization of an influenza vaccine did have Guillain-Barré syndrome, that would be a contraindication. We now know that flu vaccines can be given to those with non-severe allergies to latex or egg. MMR vaccines can be given to those with a positive TB skin test. MMR vaccine can be given to breastfeeding mothers, and it can be given if there's immunodeficient family member in the household, and it can be given to those who have asymptomatic or mildly symptomatic HIV infections. DTaP was one of the vaccines. The DTP vaccine was one of the vaccines in the late 80s that began a lot of the discussion about vaccine side effects. And the DTP, for those in the audience who actually have given it, probably remember that vaccine had quite a few side effects, including fever and some high fevers causing febrile seizures and inconsolability in children. But at this point, the DTaP vaccine, a cellular pertussis vaccine, a caution or fever is not a caution or a precaution or contraindication to receiving that vaccine. Either is having a seizure less than 3 days after a previous DTaP dose. Having a family history of seizures or SIDS is not a precaution or contraindication, as is having a stable neurologic condition such as cerebral palsy. Well-controlled seizures or developmental delay are not precautions or contraindications, although I would say checking in with your neurology colleagues about the controlled nature of seizures is always important before giving vaccine. So how are we supposed to remember all of this? So one of the things that we've done at Maine AAP, at the MMA, and with our osteopathic colleagues at MOA is to develop a request for medical exemption mandatory immunization school form. It essentially takes the ACIP contraindications and precautions to vaccination and puts them in the checklist. MD, DO, and PPA can choose the vaccine, can choose it being temporary through a certain time or a permanent contraindication, and then choose what contraindication they're selecting a medical exemption for. We have a form also for childcare, and both of these can be found on the Maine AAP website. What if there is a contraindication or precaution on that is not listed here? There is this section here at the bottom where that you can choose other and attach kind of an explanation, and then you do an attestation by filling out the rest of the data here. This form can be used and sent to our school nurses as an indication of a medical exemption, and I'm really grateful to the school health committee who has looked this over and vetted it from their perspective. So in terms of an IEP exemption process, so a student, as I mentioned, with an IEP on September 1st has to obtain counseling stating that the provider made the parent or guardian aware of the risks and benefits associated with the choice to immunize or not to immunize. So I know some of us would feel comfortable doing this and some of us feel a little at ease at providing this. So the resources to assist you are one, the vaccine refusal to vaccinate form that provided by the AAP is documentation of counseling, and I put the link here. And then the other form to assist you is the Maine DOE. It does have an immunization exemption form with the web address printed here, and this is the form on the right that can assist you. I would recommend doing your normal sort of counseling and using one of these two forms as documentation of counseling. One of the lighter, more positive side effects of COVID-19 is it's very much has strengthened the communication pathways between school staff and providers' offices, as I'm sure you are well aware. Providers will need to continue to be in contact with schools about temporary or permanent medical exemptions for students. Typically, the medical exemption process is a once-a-year process that school nurses would do in September, and then they wouldn't look again until the following September, but this year we'll need to have a more rolling analysis of medical exemptions. And Maine AAP continues to work closely with DOE to ensure that there are appropriate and effective lines of communication. Please do reach out to any of us at Maine AAP if you are having difficulty in communication or are having barriers into communication. So as we head here into late June, I want to talk a little bit about catch-up schedules. I think most of us are aware that the catch-up schedules for the CDC are divided into 4 months to 6 years and 7 to 19 years. There are vaccines that people age out of, particularly at kindergarten age, that Rota, Hib, and pneumococcal people do age out of, and some vaccines have different number of doses at older ages. So it's important for us to be up to date on those catch-up schedules. I think particularly it's important for us to understand how long it takes to be caught up on these some of these vaccines. And one of the reasons in working with legislators that I and others advocated for a long rollout period to September 1st, 2021 from 2019 was particularly for DTaP, which does take a long time to catch up on if one has 0 immunizations to it. So here's the catch-up schedule: 4 weeks between dose 1 and 2, 4 weeks between dose 2 and 3, 6 months between dose 3 and 4, and if they do require a fifth dose, 6 months between dose 4 and 5. So that is a whopping 13 months for catch-up. So this is one of the reasons why we're hoping to get out the word early to get people caught up, but the pandemic has certainly caused some significant barriers. But as a pediatrician in practice, one would want to certainly start on that DTaP catch-up schedule as soon as possible. Polio is 4, 4 doses. If the 4th dose is given before the 4th birthday, an additional age-appropriate IPV should be given on or after the 4th birthday. So when we look at the catch-up schedule here, IPV, depending on your age, can take 7 or 8 months to catch up on fully. MMR has a catch up of 1 month, right? Because the MMR doses can be 4 weeks apart. The 2 doses can be 4 weeks apart. And varicella, because of how it is written in the regulations at this point, the total catch up time is 0 months because we can just do the one and done in terms of varicella. Again, to remind us that the 7 to 18 year catch-up schedule is different, and particularly challenging in the 7 to 18 year catch-up schedule is Tdap or any of the tetanus, diphtheria, pertussis containing vaccines. The CDC has this wonderful sort of decision tree help tool, and I put the PDF link right here, but it helps you understand if somebody is 7 through 9 years and they've had 2 previous doses of DTaP, TD, or DT, TD, or DTaP, what and when that dose was given, what you should do in terms of the next dosages. So I really recommend you after this, if you are a provider who gives Tdap catch-ups or DTaP catch-ups, to go and find this PDF and print it out, particularly for yourself and your staff, because it is helpful. There's another one for polio and I think another one for Prevnar on there as well. So it's a great tool for us. So just running us through a sample catch-up for a 5-year-old who comes in with no vaccines. I think so first of all, we would need to, if they came in today, we would, and they said, okay, let's just get it done. We would give them their first DTaP, their first IPV, their first MMR, and their first varicella. So certainly this could be the standard Kinrix MMR-V combination. I don't own stock in any pharmaceuticals, so any combination of these vaccines would be fine. And because they are past that sort of fragile age of seizures with combo MMR-V, of course, we can give them together. So then in 4 weeks, they could come back for their second DTaP, their second IPV, and their second MMR. They would then be immunized against MMR. And 4 weeks after that, they could come and get their third DTaP. 6 months after that, they could get their third IPV. And this IPV would be the final dose because the child is greater than 4 years and the second dose was 6 months ago. And then finally, they can get their 6 months later, can get their fourth DTaP. And then this would be their final dose because they're greater than 4 years old. So just an example of how you can maximize or minimize the time between doses on a kindergartner with no vaccines. I want to take a moment, and I'm not going to talk about catching up a 7th grader, but the expectation is that a 7th grader who has a required Tdap as well as the meningococcal is also up to date for all prior immunizations. So a 7th grader does not just need Tdap and meninge, they do also need to have vaccination against the rest of the diseases that were required for kindergarten school entry. So I'm going to stop here and look to see if there are, I don't see any questions in the chat box or in the Q&A. So I'm going to do, while people think about the questions that they have, we have about 20 minutes to do kind of question and answer. But while you think about your questions and put them in the question and answer box, I'm going to go through some true and false questions just to, and go through some questions that I've been asked over the months leading up to this rollout. So can naturopaths give medical exemptions? The answer is no. Underneath Maine's vaccine law, only licensed medical providers that hold an MDDO, NP, or PA can give medical exemptions. We are carefully anticipating the rollout of the regulations here to ensure that, and have advocated that only licensed Maine providers can provide medical exemptions, but we do anticipate that there will be challenges to naturopaths wanting to give medical exemptions as well in the future. So the law does not apply to private schools. Another statement that I've heard, and that is incorrect. The law does apply to all institutions that previously allowed attendance with philosophical or religious exemptions, including private schools. Another true and false, HPV is required for school entry. Hopefully we all can answer that one now, that is false. And students are not required to be protected against hepatitis A, Hep B, HPV, HIV, rotavirus, tuberculosis, flu, or COVID-19, although we do recommend these immunizations through ACIP recommendations. Next, true or false, a patient of mine with a current IEP for the 2021 school year from 2019 can be exempt from vaccines for any reason as long as I provide a statement that I counseled them. And that would be true, that we as MDDOs and PPAs may be asked by parents to provide a counseling note for a patient of yours that had an IEP that is current and previous. Immunity titers will be an acceptable alternative to vaccination as proof of immunity. The answer here is true, that laboratory results or medical records demonstrating the immunity will be considered acceptable evidence meeting the immunity requirements. At least that was per regulations previously, and I anticipate that will be included in regulations forward. My patients need a medical exemption from an MDDO and PPA, or they will not be allowed to attend in-school person. I think that answer is true. Please don't disregard the blackout period for COVID vaccine. It's a place reminder to remind me that there is no blackout period around the COVID vaccine now for catch-up schedules via the AAP recommendations about a month ago. The way that we read the law currently is that we do need, children do need a medical exemption on September 1st in order to attend school. I do anticipate that there may be a grace period that superintendents are given by the regulation, but can't say that. I'm going to go and answer some Q&A, and then we'll go back to some of these questions. So Dr. Wallace was asking about if a provider gives a temporary medical exemption, is there an avenue or mandate for that for physician to follow up with the school when that exemption is no longer valid? So my suggestion here is that there's no, unless we get something written to that granular level in the regulations, I would think not. But our school nurse colleagues are certainly going to need to look at temporary medical exemptions, and they would be the ones to tell a student or a student's family that they, as of upcoming Monday, by the way, unless you obtain another temporary medical exemption, you're not going to be allowed in school. To be determined how school nurses will be handling that. But if you are using temporary medical exemptions, I would recommend that you have a way of a tickle file or something to be aware of when the next temporary exemption is required. Dr. Wallace also asked if there are any repercussions for physicians who fill out bogus medical exemptions. So when it comes to vaccine law, we do know that there are several iterations by seeing what happens in our colleagues, particularly in California, who have gone before us. The first iteration of the law is to require vaccinations as a condition of school entry unless there's a medical reason for a child to not receive an immunization. And then subsequent tightening of those regulations requires not only being clear about the reasons for medical exemptions by having medical exemptions approved only by the state health department, and chasing down those individuals who, at least in the California law, were providing medical exemptions for a fee with not following kind of standard medical exemption reasons. So most notably, Dr. Sears did have his license removed from the state of California Medical Board for giving a medical exemption that was not deemed appropriate. And so, in the future, we know that we're not going to be able to fix all the potential problems with the rollout of this law, but we will have to continue to be diligent and look at the next layers of requirements to ensure that our community immunity rates in kindergartens and schools are robust. There is a question, any idea how many children in Maine have an IEP? Has there been an increase in families seeking IEPs? I'm not sure. I don't know the data on how many children in Maine have an IEP, but I do anecdotally know that there has been an interest in obtaining an IEP as a way to secure a philosophical exemption. Dr. McCarthy asks about, is there going to be monitoring of lab exemptions, especially after incomplete immunization? I'm not, in terms of the data collection, it would be the Maine CDC and the DOE and the school nurse program that would be collecting the medical exemption forms, providing any sort of analysis of the individuals that are providing medical exemptions or the reasons for medical exemptions. This is one of the reasons why the Maine AAP is strongly encouraging providers who write medical exemptions to use the medical exemption form that we have given, so that we can be tracking those reasons for medical exemptions and following them over the years. And in terms of increasing the list of required vaccinations, if vaccines, say we wanted to add that second varicella or COVID vaccine became of interest for school-age children, there would need to be a public hearing about that, and would be a very public, well publicized public legislative process. So for those parents who are concerned that vaccines will just sneak their way onto lists, that is not how vaccines are added to the school mandate. They are added through kind of public hearing and testimony. So I think that's important to know. I'm going to go back and talk about a couple other questions while we wait for some more Q&A questions to come in. For kids who are over the age of 7, do they just need to be caught up per CDC guidelines for required vaccines? For instance, if they're entering kindergarten, they need 4 IPVs. If they start after they are 7, however, they only need 3 to be compliant with ACIP and CDC recommendations. So without further detail in the regulations at this point, I would recommend that we catch kids up for the immunizing agent that's appropriate per CDC and ACIP recommendations. And I think that is the spirit of the regulation and law as we move forward as well, but we'll see as soon as regulations come out. Another question, vaccination should be up to so here's a question about the COVID blackout. My patient got her first COVID vaccine 1 week before she was to start the catch-up schedule for kindergarten. Clearly, we're not giving COVID vaccine to kindergarten folks, but she was going to start the MMRV, DTaP, IPV. Can I still start the catch-up schedule? And the answer is yes. The ACIP approved co-administration of the COVID vaccines and other vaccines, and this is the publication to support that. My patient is a 7th grader and has no vaccines. Do I need to vaccinate them for kindergarten and 7th grade vaccines, or just 7th grade vaccines? So again, as far as the interpretation of the law at this point, children need to be up to date on vaccines required for their age and grade, as well as up to date on previously required vaccines. So some unknowns that are still out there for many of us as we're waiting the clarification in rulemaking. Will out-of-state MD, DOs, and PPAs be allowed to write exemptions for Maine students? Will there be a grace period for vaccine catch-up? Unclear. It is noted at this point in regulations that superintendents can give a one-time grace period to families, but we don't know if that will be available to families, particularly because of the long rollout of this law. What loopholes will be found vis-a-vis the questions about bogus immune exemptions and proof of immunity? What are the implications of this law for employer vaccine mandates? There is some religious and philosophical exemption verbiage in employer vaccines mandates that we are still working with MMA and other leaders around the state to determine what those implications are for employers. And what will be the impact on community immunity rates at school? So will children, will we see those ultimately see those community rates rise? Will there be an increase in homeschooling for people who choose not to vaccinate their children? It'll be interesting to see kind of the movement around this new law. We do see typically in other states that have implemented this law that the vast majority of individuals will go ahead and get vaccinated, and there will still be some who vehemently oppose vaccination for their children and will find other methods for education. So I'm going to stop there, remind you that the text attendance number is 43976. I'm going to stop and see if there are any other questions out there. Carol, did you see any questions that I didn't answer?
No, I think we're caught up.
Great. Carol, was there anything that you wanted to add, or I'll give a moment to, we have about 8 minutes left here to see if people have questions.
No, thanks. That was a good overview. And I think certainly COVID has presented more challenges to implementing this. But I think also, as you mentioned, has made people aware of the importance of immunizations.
Yeah, certainly that and the necessary role that our schools play and why it's so important to keep them open. And I hope this law will prevent those sort of outbreaks that we were seeing before in terms of pertussis and chickenpox and others. So the Maine AAP will continue to try to update, particularly when regulations do get put out. Thank you, Dr. Gordon. I wish I had an idea. I had thought that the regulations would be out much sooner than now. I believe I've heard that they're at the Attorney General's office being reviewed for legality, but I would have hoped that they would be out by now. So I'm kind of watching every day to see what the release is. But when they do come out, we will have to review them and we'll have an opportunity for comment. So if pediatricians are interested in that, please do email me and know that that the Maine AAP and the MMA and the MOA will be giving feedback on the issues within the regulations. One of the concerns, in addition with clarifying the licensure of the state of licensure of different providers, is the word immunizing agent is also a concern to me in the regulations, because there are various homeopathic immunizing agents that have been used. In Canada, no-sodes are often considered an alternative to immunization, although they have no proof of providing any immunity. So I'm also very interested in making sure that that an immunizing agent is an FDA approved immunization as well. So we'll certainly be communicating to the broader community when those regulations do come out.
Any other questions that people have? Okay, I guess we'll finish a little early. Thanks, Laura, and see everybody back in the fall. And I think in the fall, I think Dana will be open and probably at a reduced capacity, but I would envision that we probably will have a blend of in-person as well as Zoom. Thanks.